You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for March 13th, 2020. This week, we're talking coronavirus. Well, what a 7 days it has been. I'm recording this podcast on Friday morning, and I'm afraid what I will say will be outdated by this evening. Last Friday, as the virus began in the U.S., and President Trump reassured the nation that the 5 cases would soon be 0, I speculated on whether medical conferences would be canceled. You all know the news. Not only are major medical conferences canceled, everything is canceled. The Tour of Flanders and Paris-Roubaix canceled. The NBA canceled. March Madness, PGA tournaments canceled. Disneyland canceled. Even my beloved park runs canceled. Your retirement accounts almost canceled by a plummeting stock market. The exponential spread of coronavirus through Europe and the U.S. has given our time a post-9/11 feel. I follow about 1,500 people on Twitter. 1,495 of them are tweeting about COVID-19. I know this is a cardiology podcast, but it's as if there is no other news. It seems tone-deaf to think or talk about anything else. It began last weekend. The stories from Italian docs. I can't verify all of it, but I have friends who have confirmed that yes, entire hospitals have been turned into ICUs. OR rooms where hips and gallbladders were done weeks ago, now ICUs. The most wrenching words from Lombardy were the triage decisions. All doctors make triage decisions, of course, but from the perch of my little idyllic suburban hospital, it's hard to imagine my colleagues deciding on which patient with the virus will get an attempt at life-saving therapy and which will not. Now, while these stories were coming out earlier in this week, I was busy in the EP lab ablating premature beats, making sure all the pre-op H&Ps were done, the boxes checked. Colleagues in Italy, China, Iran, South Korea, transforming hospitals and operating rooms into ICUs. An Italian medical leader died of COVID-19, and other clinicians were fighting for their lives because they too were infected. Electrophysiology never felt so damn small, so much like a first world problem. Now, don't get me wrong, I love our field and I think we help people immensely. But catheter ablation and ICDs, hip bundle pacing, all this takes the back seat when a virus is spreading and sickening thousands. A UCSF expert panel did the rounds on social media. Their ID experts predicted a few things. Containment of this virus is hopeless. Now it is all about mitigation to flatten a curve, or basically take away the peak of people getting sick at the same time. They also said that by all accounts, the U.S. is on the exact same trajectory as Italy, only we are 7 days behind. They predict, and sit down for this, 40 to 70% of the U.S. population will be infected over the next 12 to 18 months. After that level, herd immunity will slow the spread of the virus. The problem now, of course, is that there is no latent immunity in the community. If you assume a 1% mortality, which is still 10 times influenza, this means about 1.5 million Americans will die from COVID-19. And this sobering stat, of course, assumes no drug is found effective. Now, the death rate varies by age, and elders may have rates of death at 10 to 15%, but early reports both in preprint servers and mainstream journals, have shown that young people can get very ill with this disease. And sadly, the early data also looks like people can be infectious 2 days before the illness and then infectious throughout an entire 14 days after symptom onset. Let's move on to a couple of themes. First is societal. Whether it's through ignorance, hope, or extremely bad political leadership, or a combination of all of these, much of society seemed to forget basic math, that is, exponents. The exponential spread of the virus was predicted, but was ignored. It is now happening. Even this week, some of my doctor colleagues in my hospital remained indifferent. I'm like, have you not heard the stories from Italy? And most of the doctors that I work with are not on social media, so no, they hadn't heard it. So I tell them, I say, imagine our operating room full up with ICU patients. Imagine half of the staff infected with the virus. Imagine urologist and orthopedist or even electrophysiologist managing patients on ventilators. That's the scene in Italy, and you want to keep doing stress tests and colonoscopies as if nothing is wrong. Yesterday, Thursday, I walked through the surgery waiting room. It was full, families waiting for their loved ones, most of whom were having elective surgeries. But then, by Thursday afternoon when I left, there seemed to be a groundswell of awareness. Perhaps it was all of the cancellations. Perhaps it was even Joe Rogan's podcast, which is listened to millions, in which he talked to a University of Minnesota ID doctor who spoke the reality. Or perhaps it was the reports of a National Guard blocking off an entire suburb of a New York City. Or the stories on social media of sick people not being able to be tested. People, at least in Louisville, started to get serious about social distancing. We talked about canceling elective cases, doing remote checks of pacemakers, and we talked about doing virtual visits with our stable outpatients. The second theme that I think is important here is that we have an administrative-heavy healthcare system here in the U.S. The COVID-19 crisis will expose the problem with bureaucratic bloat in our system. I mean, testing is the obvious example, right? I learned that a real-time PCR test was approved in South Korea back in February. And we have a CDC and FDA that are documented as having either blocked or slowed this. 2 U.S. colleagues have already messaged me to say they have patients on ventilators with classic COVID-19 symptoms and can't get these patients tested. These are big hospitals. And mainstream media is awash in stories about patients unable to get tested. Now, testing won't stop the virus, but it would surely help slow the spread of it. Another example of administrative bloat is the slowness of stopping routine care in order to prepare for this. As I said earlier, our hospital continues to do routine cases. Our clinic, my cardiology clinic, has vulnerable patients coming in for routine care. Myself and a handful of doctors took it upon ourselves to call patients, check on them, and if okay, let's reschedule. It belies all common sense to bring a patient into an area in which COVID-19 is surely spreading, an area like a hospital. An irony here is that in some ways the VA healthcare system is more nimble than the private system. Many of my colleagues at the VAs have already moved to telemedicine. Of course, they can do that because in the VA, taking care of the patient is all that matters, but in the private system, virtual visits are discouraged because no one can get paid. The third theme is about leadership. We haven't seen anything like this in my lifetime. When sick people come to the hospital and begin to overwhelm the system, we will need clinicians, nurses, and doctors to lead. ICU docs and nurses will be first to lead, but then other docs may have to step in. And the vast majority of people on hospital payrolls have no patient contact. These folks will need to follow the lead of the doctors. Doctors, not administration folks, will have to say when we need to build tents outside the hospital for triage, or when to close off entire wards for only COVID-19 patients. Clinicians will make it clear that policies that punish workers for staying home when ill are harmful to patient safety. It's always been this way, of course, but COVID will make clear the difference between a facade of patient safety and real patient safety. COVID-19 scares me, but it also makes me optimistic that a true health emergency will help bring out the best in the healthcare profession. The fourth theme is changing of norms. COVID-19 will require that we change our norms. For instance, as my colleague Kevin Driver reminded me, some states are streamlining licensure requirements to get more workers. We need to do that, and there's no reason why we shouldn't have streamlined licensure requirements always. Virtual visits should become reimbursable and encouraged. COVID-19, if it lasts for a year or two, also may demonstrate to doctors and patients alike exactly how marginal much of our normal routine care actually is. This may be a small consolation of the COVID-19 virus. The fifth theme is this business about social media and the communication of science. Now, while some mainstream media is doing great work, my colleague James Hamlin at The Atlantic especially is someone to follow. The place to be to keep on top of this is social media, primarily Twitter and blogs and podcasts. The former FDA director, Scott Gottlieb, has an incredible Twitter feed. You should be following him. Another person who's doing beautiful work with curation is my friend Dr. Bobak Zianon. You can simply set up a column also for the COVID-19 hashtag. Print and TV journalism is woefully late to stories. I mean, by the time my paper comes in the morning, I've already seen these stories the day before. Digital media is the place. I even suspect that Joe Rogan's podcast had a lot to do with turning of public opinion. I wrote a brief column this week on the Heart.org Medscape on COVID, and in it I cited an incredible interview that JAMA editor-in-chief Howard Boschner did with Dr. Anthony Fauci. This 60-minute interview podcast was a trove of great material. And the thing with podcasts and these longer Twitter threads is that it allows for longer form information. And I really think that longer form is coming back, and given the uncertainties of COVID, people will want more, not less discussion of this. The final theme. The preprint servers and Twitter case reports are coming on about treatments of COVID, different kinds of approaches to very ill patients. There's a push to get compassionate use of antiretrovirals, for instance. And the Chinese experience emphasized the use of corticosteroids, but others don't agree. That's the thing. We don't know what treatments work and what treatments don't work, and thus COVID-19 offers us a golden opportunity to demonstrate the power of randomization. Since COVID is not universally fatal, some patients get better on their own. The only way we're going to learn about effective therapies is to randomize patients. We'll need control groups. I really hope that this crisis shows us the value of early pragmatic RCTs. So that's it for this week in cardiology. I'm sorry, I just could not see any value in discussing cardiology topics during this crisis. Please, if you didn't like this, I'd welcome feedback. And of course, I will return to cardiology. But right now, it seems tone deaf not to address the potentially biggest health crisis of a generation. And to my fellow healthcare workers out there, please stay as safe as possible. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.